Good evening, ladies and gentlemen. Welcome to the Signal APAC Summit 2021. We are so pleased to have all of you attending the Signal APAC Summit. My name is Choi, and I will be the moderator of today's webinar. I would like to introduce myself briefly before we start. I'm a professor in Seoul National University Hospital. Again, thank you for your time at such a late hour, and I hope all of you get lots of takeaway today. Today, we are going to focus on how to detect Afib on time by using a wearable ECG monitoring device. There will be 3 sessions presented by each different speaker. The first session will be presented by Dr. Yong-Soo Baek, and he is going to talk about why early detection of asymptomatic Afib is important. The second session will be presented by Dr. So-Ryung Lee, and she is going to talk about the clinical value of long-term ECG monitoring. The last session will be presented by Dr. Junbom Park, and he is going to talk about how to decide which wearable ECG device is right for clinical diagnosis. After all 3 sessions ended, we are going to have a Q&A session for 30 minutes. Please leave your questions or thoughts in the chat box. If you are not able to answer all the questions during the given time, then we will contact you separately. I would like to introduce our first speaker, Dr. Yong-Soo Baek. He is an assistant professor in the Division of Cardiology at Department of Internal Medicine at Inha University Hospital and Inha University College of Medicine. He is going to talk about the very first session today and talk about the importance of early detection of asymptomatic Afib. You may leave your question and thoughts in the chat box. Our speakers are going to go over the question after they ended all the session. So Dr. Baek, please.
Thank you, Chairman. Good evening, ladies and gentlemen. It's a great pleasure to present my topic in this great summit. As we know, Afib, atrial fibrillation, is most common arrhythmia. Afib is significantly increased risk of mortality, heart failure, dementia, and worsening quality of life, and hospitalization as well as stroke. And Afib is also a progressive disease. As we know, Afib is progresses from paroxysmal, persistent to permanent atrial fibrillation. Is more disease progress AF and more remodeled, and it is very difficult to manage or treat this disease. For example, Figure A shows the MRI-LZ of paroxysmal AF patient. Figure B shows the persistent AF patient MRI-LZ. You can show the significantly higher MRI-LZ level. This MRI-LZ means it's atrial fibrosis progressive disease. So, and stroke and mortality is related to AF progression. Left Kaplan-Meier curve shows based on active A and adverse study database. You can show the persistent and permanent atrial fibrillation is associated a higher hazard ratio of stroke risk compared with proximal atrial fibrillation. Right Kaplan-Meier curve, you can show the persistent AF patient is higher all-cause mortality hazard ratio compared with proximal AF in located AF study. And how about long-term outcome for asymptomatic versus symptomatic atrial fibrillation? This European cohort data, real cohort during 10 years follow-up duration. And in this cohort, persistent or permanent slow ventricular rate during AF, and history of diabetes and male gender were independent risk factors for asymptomatic AF presentation. You can show the right side the Kaplan-Meier curve. And this asymptomatic atrial fibrillation patient is significantly associated with progression to permanent AF and ischemic stroke compared with symptomatic atrial fibrillation. And another is USA court. In this court show also atypical and asymptomatic atrial fibrillation is conferred a significantly higher risk of strong risk CV death and all-cause death and compared to typical AF, adjusting relevant risk factor. And there are definite stroke prevention gaps in AF and stroke patient. You can, in this court data is large scale data related to ischemic stroke in Sweden. Among this court, AF related stroke is about 33%. AF known at the time stroke is about 24%. Among these patients, about 2% is did not receive adequate medication. And AF unknown is 9%. This patient need to screen for AF before stroke. So this data suggested about 29% this patient would be preventable stroke risk. So early AF detection is matter because there is a 5-fold increase in ischemic stroke risk for AF patient. AF detection in cryptogenic stroke patient enable treatment change from antiplatelet agent to NOACs. There is a 67% decrease in AF stroke risk with oral anticoagulant. So this current time is there are many AF screening tools. It's ESC guideline and in opportunity screening including just pulse palpation, BP check, and PPG based smartphone and smartwatch and continuous recording including ECG patch and ICM. You can see the AF detection yields from 1.4% to about 34% according to this continuous monitoring. And last year, as you know, is 2020 ESAF guideline update. As key update is CC to ABC. This C is confirm AF. As newly updated confirm AF, as clinical AF definition is entire conventional 12 ECG or single read ECG tracing longer than 30 seconds of AF. This AF including wearable recorded ECGs, regardless of AF symptom. So there are many AF screening studies related to cost-effective opportunistic screening and systemic meta-analysis. Based on these studies, ES guideline recommendation is opportunistic screening for AF by pulse taking or ECG rhythm strip is recommended in older 65 years old class 1B recommendation. You can see the many various screening tools, new wearable ECG monitoring. As you can see the figure A chest strap device and PPG-based wrist and smartwatch, and ECG function is included smartwatch such as Apple Watch, and long-term mobile holter, and 7 days or 14 days wearable ECG patch, and handheld ECG such as AliveCo cardiac mobile and ring-type wearable device and so on. These many various AF screening tools show is a high performance status, a high sensitivity and specificity compared with the standard 12 lead ECG. But it is very difficult to compare it directly because of this. Each study population is very different and very different characteristics. And in terms of patched ECG, is a representative trial. This mSTOPS RCT was published in JAMA 3 years ago. This large-scale study is 1,300 patients eachly, randomized to immediately patch disease group and another delayed patch disease group. This group compared with is matched control group. This is the result. You can show the significantly higher, about 3 times is cumulative rate of post-diagnosed AF compared with control groups. Interestingly, first increased rapid curve is mainly drive the immediate patched group, and second rapid rise in this curve is due to mainly in the delayed patched group. And days of ECG patch wear until first diagnosed atrial fibrillation. Interestingly, the median duration of time after each ECG patch placement until about 2 days, mainly within 7 days. And another is famous study is the REALS AF study using this handheld ECG. This study population group is relatively high risk patient groups. It's older than 65 years old and CHA2DS score 2 more point. And interestingly, just this intervention participants group is acquired i.SigNal only twice weekly over 12 months. Interestingly, and this Kaplan-Meier curve show the about 4 times is detection of AF compared with the routine group. And 2 years ago is approach study, the approach study. This is very large scale assessment. Is 400,000 participants. This flow chart is firstly smartwatch, including an irregularity detection program as the tachogram. This PPV-based tachogram, if the multiple irregular tachogram in the sender notice to the study doctor, and study doctor visited by video the participant, and then study doctor is decided as eligible for patched ECG monitoring. And result is disappointingly only 0.5% only receive a irregular pulse notification. But this large scale population is very young, relatively young age and healthy people. So in sub analysis is less than 40 years is younger population. Is irregular notification percentage is less than 1%. But relatively older population and older 65 years old, if irregularity detection rate is 3.2%, and subsequent among received ECG patch monitoring, this 1 week ECG patch monitoring revealed AF in 34% of monitored participants. I think this study is meaning is this table is very important. End of study survey. You can see the notification subgroup irregularity reported a greater incidence of stroke, heart failure, and myocardial infarction than non-notification subgroup. The notification subgroup was also more likely to start receiving adequate medication. And in terms of early AF rhythm control therapy, this IST-AF-NET4 trial was published last year in NEJM. In this trial is a high-risk group, AF patient. Interestingly, early AF within 1 year duration of first documented by ECG. This patient is a randomization of and first early rhythm control and another user care group. Early rhythm control group included antiarrhythmic drug and AF ablation, and but user care group only rate control and anticoagulation by guideline, limited to rhythm control. Primary outcome including hard endpoint, death, stroke, hospitalization with worsening heart failure or acute coronary syndrome. Median follow-up duration 5 years. Interestingly, surprisingly, early rhythm control is associated significant risk reduction is 21% of hard endpoint compared with the user care group. So in this study, in conclusion, is early AF rhythm control therapy was associated with lower risk of adverse severe outcomes. I think this study is very important study because early AF detection and early rhythm control is very important, suggested. And last month is in IST-AF4 trial sub-analysis. In this presentation, in terms of asymptomatic versus asymptomatic, because current guideline recommendation, for example, AF ablation for only symptomatic AF patient. So in IST-AF4 trial included asymptomatic ERA symptom scale grade 1 is about 400 patients were included each group. And as Kaplan-Meier curve, you can show the asymptomatic at baseline. Even if asymptomatic, the effect of early rhythm control in this outcome was almost the same, identical in symptomatic and asymptomatic. And symptoms improved without did not differ to each groups. So in this sub-analysis concluded the clinical benefit of early systemic rhythm control was not different between asymptomatic and symptomatic patients. So I think that this result have a very potential impact with asymptomatic early AF patient especially. So for AF detection sensitivity, so more longer screening type and frequently screening interval, you can see the AF detection sensitivity is better. So I think this 7 days wearable patched ECG is more advantageous than other screening tools. First, for continuous monitoring an asymptomatic AF patient, then event recorder, including smartwatch event recorder, is more advantageous, and Holter monitoring is more continuous monitoring. And second, for non-invasive ICM implantable loop recorder is continuous monitoring is have the advantage, but the invasive and expensive. In terms of this aspect, this 7 days wearable patched ECG more advantageous than other screening tools. So, ladies and gentlemen, in summary, number 1, early detection and rhythm control therapy of AF would be very important. Monitoring of AF detection is required regardless of AF-related symptoms. Especially, I think in my opinion, high-risk population, higher CHA2DS2-VASc score or diabetes mellitus because of autonomic dysfunction and silent AF. So in this patient, his early detection and rhythm control is very important. And number 2, continuous monitoring for prolonged duration provides the greatest ability to detect AF. And number 3, however, smartwatch and ICM not yet widely available because of their cost and invasiveness. So a new cost-effective strategy to meet the unmet need and improve AF detection. And number 4, considering convenience, accuracy, and simplicity in terms of cost effectiveness, this device would be a good option for the detection of AF detection. Thank you for your attention.
Thank you, Dr. Beck, for your nice presentation. Dr. Beck emphasized the clinical implication of the asymptomatic atrial fibrillation. So I think we can summarize that the asymptomatic AFib is a very important also progression to the permanent atrial fibrillation. And he presented a lot of randomized clinical trials related to the asymptomatic atrial fibrillation. So now we are going to move on to the next sessions. Here I would like to introduce our second speaker, Dr. Soryong Lee. And Dr. Lee is assistant professor in the internal medicine department of Seoul National University Hospital. She is going to specify the clinical implications and benefit of long-term ECG monitoring compared to short-term ECG monitoring. Again, you may leave your questions and thoughts in the chat box. Our speakers are going to go over the question after the end of the session. So Dr. Lee, please.
Thank you for a kind introduction. Good evening, everyone. I'm Dr. Lee from Seoul National University Hospital. I will share with you the topic about clinical implication and benefit of long-term ECG monitoring compared to short-term ECG monitoring. The diagnosis of arrhythmia is simple but not easy. To diagnose a certain type of arrhythmia, we need electrocardiogram. However, the manifestation of most arrhythmia is paroxysmal. It is important to diagnose whether there is an arrhythmia that can explain the symptoms when a patient has symptoms. Regarding classic tool, there have been 12-lead ECG and a 3-channel 24-hour Holter monitor. We are still using these in our daily clinical practice. In Korea, usage of Holter monitoring is continuously increasing. What images comes to your mind when you think of Holter monitor? This image showed the Holter device and how we attach this device on the patient's body. But these pictures are closer to reality. Holter is quite inconvenient to wear all day, also unable to diagnose if arrhythmia is absent during 24 hours. So there are some unmet needs for continuous ECG monitoring for arrhythmia detection. First, poor convenience. Second, depending on the frequency of the symptoms, 24-hour Holter monitoring may be insufficient for diagnosis. In fact, in my clinic, some patients said, on the day I wore it, there was no symptoms. It's a very frequent situation. To meet these unmet needs, several new tools have been introduced. We can categorize this into two types, provider-initiated and consumer-initiated. Single-lead ECG patch is included in provider-initiated tool, and smartwatch is included in consumer-initiated tool. These devices already deeply involved our daily clinical practice. In newly updated Afib guideline, Afib lasting longer than 30 seconds through single-lead ECG tracing is defined as a clinical Afib. Today, I will focus on the data from single-lead ECG patch device among provider-initiated tool. As you know, there are several types of single-lead adhesive ECG monitoring. Some are patch types, or some are single-lead, including one short line with 2 circular small patches. Some included memory chips, some does not, and some has extended battery longevity from 2 weeks to 1 month, or some last just 3 days. As a user, we can have 3 questions before using this new device. First, is this more convenient than Holter monitoring? Second, the signal quality from this device is good enough. And third, the diagnostic ability is equivalent or non-inferior to 20-hour Holter monitoring. And there will be additional benefits. In this case, longer duration, extended monitor can be the additional benefits. Answer for first question, is this more convenient than Holter? The answer is definitely yes, more convenient. In this report, 2 weeks adhesive patch ECG is more comfortable, less affected of patient activity of daily living. Study patients prefer to using single-lead ECG patch than 20-hour Holter monitoring. And this study reported similar findings. Study patients who simultaneously attached the single lead ECG and Holter monitoring felt that single lead ECG is very convenient with none to minimal skin irritation, and most patients satisfied a single lead ECG during examination. Then we will find answer for second and third questions. The signal quality is comparable and the result of single lead monitoring is non-inferior to reach a diagnosis. The answer is yes. When simultaneously monitor both Holter and single lead ECG patch for first 24 hours, the Afib burden from two devices were highly consistent. In this study, we performed head-to-head comparison between Holter and single lead ECG in patients had symptom or arrhythmia other than Afib. Two devices showed excellent agreement in all the basic parameters, and these figures showed good agreement between two devices for total QRS complex and ventricular, supraventricular ectopic beats. Also, two devices showed good correlation in minimum, maximum, and average heart rate and maximum RR intervals. Also, two cardiologists independently read the ECG using single lead ECG and Holter and made a coherent diagnosis for all participants. So we get answer yes for question 1, 2, and 3. Now we look into the data about additional benefit for single lead adhesive ECG for longer monitoring. In this study, in 146 patients, researchers compared between conventional Holter monitoring and 14-day adhesive patches. In single lead 14-day monitoring, only about 2% of cases are missed by Holter, but the longer period use, the more cases are founded compared to Holter. So this 36 more arrhythmia detected only by 14-day ECG patch. And this study was performed in Taiwan recently, and longer monitoring by single lead ECG revealed more detection of arrhythmia than Holter. And another interesting finding is after 1 week, the new diagnosis might be saturated. For Afib screening, as Dr. Beck mentioned, that longer monitoring also beneficial. So 2 weeks monitor detected more Afib than 1 day monitoring. And this study may be interesting for electrophysiologists. Among patients with paroxysmal AF, both Holter and the single lead patch were applied. And 58% of patients showed Afib during monitoring, and 90% of first Afib events detected in 7 days. As a result of longer monitoring time, single lead patch detected more Afib episodes than Holter. And through extended monitoring, there were changes in Afib classification, non to paroxysmal and persistent to paroxysmal. And during extended monitoring, there is one patient had very long sinus pause. So these patients received the pacemaker implantation, and this one patient in Holter, there is no significant pause. So including this patient, 28% of patients had a change in their management, including treatment like antiarrhythmic drug, oral anticoagulation, pacemaker implantation, or DC cardioversion, or AF ablation. So why we focused on the Afib? Because appropriate detection of Afib is very important to prevent further clinical complications. So when we detect in patient without Afib, it might be screening for mass population, then we can initiate OAC to prevent stroke. And the second point is, as Dr. Beck mentioned, that ECG monitoring can be an important basis of active early rhythm control. So patients with recurrent of symptoms and Afib, even after the use of antiarrhythmic drugs sufficiently, should be considered as a candidate of AF. So many studies show that the benefit of early rhythm control by drug or by Afib ablation. So using extended monitoring, we can detect patients' asymptomatic and symptomatic AFib efficiently. And third one is similar with second one, and we until now we estimate the patient AFib is yes or no, but AFib is not the binary entity, so we can estimate the burden of AF after the procedure or after the treatment, and we can estimate the patient's strong risk and patient's symptom or patient's risk of heart failure in the future. So this is another indication of long-term monitoring, not screening but detection AFib for the reason of cryptogenic stroke. So in this small RCT, they randomized the extended monitoring arm and the Holter monitoring arm, and extended monitoring, of course, detected about 7 to 8-fold AFib more detected compared to Holter monitoring group. But I mentioned several studies about the single lead monitoring, and there are some limitations. Quality and performance varies depending on the various machines. So I mixed up the several devices in this presentation, but we have to check the published data for our own device, that how is the sensitivity or specificity, and how is the signal quality and the correlation with 24-hour Holter monitoring. And now we have tools. So what we need next? Extended monitoring is definitely beneficial, but require more time to interpretate because they get more information and more ECGs. So future direction should be development of automatic interpretation of ECG for clinical use. So many devices are now available, but many devices not have this kind of validation, like automatic interpretation. So this is our future direction, to validate the signal quality and a proper automatic interpretation for clinical use. So I will show you 3 cases with relevant with my presentation. And the first case, 84 years old female, and she had dizziness and syncope. The 12-lead ECG showed the sinus bradycardia, and she received several times of Holter monitoring in outside hospital, and they cannot get the clinically significant long pause. The pause shorter than 2 to 22.5 seconds is multiply detected, and she did not want to perform Holter anymore. So we tried to attach this very simple single lead ECG patch and monitor her for 72 hours. And at the first day, we can found a significantly long pause with symptom correlations. So she received the permanent pacemaker. The second case, a 76-year-old male, and he had intermittent palpitation, usually during exercise, and she performed repeated Holter, and there is nothing on his examination. And he did 7-day single lead ECG patch monitoring, and there was the ECG suspicious of paroxysmal supraventricular tachycardia, and he got the EPS and RFCA, and the final diagnosis was AV NLT slow fast, and the slow fast pathway ablation is successfully done. The third case, 64 years old female, and he had dizziness and palpitation, and she had the family history of stroke, so she very worried about the arrhythmia related with increased risk of stroke like AFib. She do 2 or 3 times of Holter, and there is some APCs and some short run PATs, and there was no AFib. And we attached her the single lead patch ECG monitoring during 72 hours, and on third day there is Afib, but first day and second day there was no Afib. So we found Afib successfully and started OAC and antiarrhythmic agent for her symptom control and stroke prevention. So let me summarize, ladies and gentlemen. Provider initiated single lead ECG patch already getting deep into daily clinical practice. And single lead adhesive ECG monitoring is simple and convenient than 24-hour Holter. Single lead ECG is simple but comparable signal quality and diagnostic accuracy with 24-hour Holter. And single lead patch makes extended monitoring easier to increase diagnostic rates. And a number of studies have been conducted to develop fast and accurate interpretation. The various studies are underway on which patient to perform and how to lead the result to clinical practice. Thank you for your attention.
Thank you, Dr. Lee, for your great presentations. So I think Dr. Lee emphasized the characteristic of the atrial fibrillation, that the atrial fibrillation is not only the symptomatic, but also the type of atrial fibrillation is a paroxysmal. So we need more longer duration of monitoring to detect the truly atrial fibrillation. And Dr. Lee emphasized that the three characteristics, the convenience and signal quality and accuracy, would be the important factor which we have to think about when we choose the wearable device. So I think now we are going to move on to the last sessions. Here I would like to introduce our third speaker, Dr. Junbom Park. Dr. Park is now Associate Professor and Director of Cardiac Electrophysiology Lab, Department of Cardiology, College of Medicine, Weihai Women's University Medical Centers. He's going to talk about how I decide which is the appropriate wearable ECG monitoring device. And Dr. Park, please.
Thank you for introducing me. My topic is how we decide which is the appropriate wearable ECG monitoring device. This is a very interesting topic. This is, as mentioned before, this is atrial fibrillation, which is irregular beat. The prevalence of atrial fibrillation has been increased as aging process regardless of gender difference. So for detection of atrial fibrillation, we have to perform the systemic ECG monitoring in the hospital, such as 12 ECG monitoring and 12 hours Holter monitoring, and implantable loop recorder. But implantable loop recorder is a little invasive procedure. So the recent ESC guideline recommend the single lead ECG, even though for the overcoming the limitation of the systemic ECG and the invasive procedure such as a loop recorder. So the screening for atrial fibrillation, the opportunistic screening for AF, by pulse taking or ECG rhythm strip is recommended in population more than 65 years old, and systemic ECG screening should be considered to detect AF in the population more than 65 years old or those at high risk of a stroke patient. Recently, the sensitivity and specificity of single lead ECG is increased compared to previous device. So we can easily use these kinds of single lead ECG in the hospital or daily life. So the Korean Heart Rhythm Society also recommend these kinds of the opportunistic screening and the systemic ECG for detection of atrial fibrillation with using single lead ECG. Interesting point. The report of the Afib screening international collaboration should recommend the Afib screening, the similar method, but in the patient with high risk of stroke patient, every 2 times per day for the systemic ECG was recommended, but every 2 times per day of systemic ECG screening is not possible in the daily life. So the single lead ECG, such as wearable device, is very important. I will show 2 big interesting study. As you know that the one study is Apple Heart study. The smartwatch this study classified conventional group and case group. In case group, the population should do the detection of atrial fibrillation with smartwatch. In conventional group, just the conventional ECG monitoring. Just notification of atrial fibrillation with smartwatch. In case group, such as notification group, has higher the rate of atrial fibrillation detection and higher change of anticoagulation. This study is a similar study compared to previous smartwatch study, but this is cardiac from alive core. This single lead ECG is kinds of the event recorder. The case group, in case group, the population should do the Afib detection performance 2 times per week. Just 2 times per 1 week Afib detection performance, the increased detection rate compared to conventional systemic ECG monitoring. This is a single lead ECG. This is not different. The previous, the cardiac mobile. This is single lead ECG is possible for the continuous monitoring, as attachment of single lead patch. So case group, the population should do the attachment, the single lead ECG for 2 weeks. After 3 months later, the population should do the attachment single lead ECG for 2 weeks. After that, we compared to the result of detection of atrial fibrillation and change of anticoagulation. Interestingly, just the 2 weeks single lead ECG group has a higher detection of atrial fibrillation and higher change of anticoagulation change. The more interestingly, the detection of atrial fibrillation was happened in the first week. So the most detection of atrial fibrillation was happened in the first week. So we can hypothesize that for detection of atrial fibrillation, 1 week single lead continuous ECG monitoring is enough for detection of atrial fibrillation. And the 1 week later, detection of atrial fibrillation is lower than in the first week. So we designed the 3 group, the randomized prospective study for how we decide which is the appropriate wearable ECG monitoring device in a high-risk stroke patient. So we included the high-risk stroke patient with acute stroke within 1 month. So conventional first group, in conventional group, the population should do the conventional systemic ECG monitoring, and the second group, performed the attachment of a single lead wearable patch ECG, and final group, the use just just the event record type single lead ECG, such as Cardia Mobile. We are processing this randomized prospective study in the 9 multi-center hospital in Korea. The total population 600, each group is 200 population. There are many kinds of single lead ECG, the smartwatch type, ring type, and event holder type, and the continuous monitoring patch type. Among them, Cardia Solo has a clinical benefit. As mentioned before, the detection of atrial fibrillation is happened in the first week from attachment of a single lead ECG. So Cardia Solo is possible for the attachment of a single lead ECG for detection of atrial fibrillation for 1 week. So Cardia Solo is continuous for 1 week. So we can, as mentioned before, we can use Cardia Solo for 1 week for detection of atrial fibrillation in high-risk patient. This is another interesting point. ECG has dynamic change, even though one pulse and one same person. So we should do the serial ECG analysis. 2 years ago, interesting result about artificial intelligence in Lancet. So this is a brief diagram of a study. The normal sinus rhythm in paroxysmal atrial fibrillation patient, normal sinus rhythm was detected just before atrial fibrillation ECG. So in this study, artificial intelligence trained normal sinus rhythm before atrial fibrillation. After that, if the patient experienced palpitation, even though normal sinus rhythm was detected, the AI algorithm can detect atrial fibrillation or not in the future. So in this study, the study group use about 1 million ECG data. After that, area under curve for detection of atrial fibrillation in the future with using normal sinus rhythm is about the 90%. It's very interesting result. So we are processing analysis with using artificial intelligence in Korean population. So in multi-center, the ECG data. So we can collect the 100,000 ECG data. After that, we reanalyze the ECG data as the reference of normal sinus rhythm. We classified the window period as 1 month and 3 months, 6 months. When the 6,000 population has a window period of 1 month as the reference of normal sinus rhythm, and about 7,000 population has the window period of 3 months as a reference of normal sinus rhythm. The first figure shows that the result of 1 month window period with using normal sinus rhythm, AI algorithm showed detection of atrial fibrillation in the future. The 1 month later, the Afib detection probability was shown as the 80%. Our result is lower than the Lancet result, but the population data is the Lancet data that was larger 10 times than our data. Even though that we shows the very a little higher performance for detection of atrial fibrillation. So we are processing the AI algorithm in the future. So yes, the window period 1 month of its accuracy is 80%. Interestingly, the when normal sinus rhythm is close to atrial fibrillation rate, the accuracy of detection of atrial Afib is higher than other case. The Professor Baek-Yong-soo give us the typical case with using the artificial intelligence. So one case, the 62 female patient, she has palpitation in emergency room, but normal sinus rhythm was detected. AI algorithm that shows the low probability of atrial fibrillation. However, she experienced palpitation in emergency room. At the time, atrial fibrillation was detected after normal sinus was converted. After that, AI algorithm showed high probability of paroxysmal atrial fibrillation. So this is interesting point of AI algorithm. This I'm showed the summary. The Afib screening is very important for detection of atrial fibrillation and preventing stroke. And the single lead ECG that shows similar sensitivity and specificity compared to conventional ECG, systemic ECG monitoring, and large 2 study such as apparatus study and the STOPS AF study shows that the single lead ECG is a clinical implication, very important clinical implication compared to the conventional ECG monitoring. After that, our Candle AF study, how we decide which is the appropriate wearable ECG monitoring in high-risk patient. Thank you for your attention.
Thank you, Dr. Park, for your nice presentations. So Dr. Park presented the wearable watch and a live core and also the cardiac solo device to detect atrial fibrillations. So now we are moving to the Q&A sessions. So there are several questions are coming up. So the first question is that what is your perspective on wearable ECG device for clinical decision making? So maybe we could share this question with the speakers. So for the first, Dr. Beck, do you have any perspective on your wearable device for clinical decision making?
Very important question. As I mentioned in my presentation, I think there is many various AF screening tools. A long time ago, there is definitely gap in arrhythmia detection and clinical implication. For example, a patient comes to our outpatient clinic for symptom, but is at the time and conventional ECG or Holter monitoring is not AF detection rate yield is very low. So this long-term wearable monitoring is AF detection rate is increased, and this clinical meaning is last year East AF AFNet4 trial is representative, give us important message, because symptom and also hard endpoint, including CV death and heart failure and hospitalization in stroke SRS. So in this result is AF early detection by this wearable monitoring is improved this CV hard endpoint. So and then symptom and asymptomatic AF patient is also early AF manages is very important. So I think this wearable device is very important in our clinical field.
Thank you, Dr. Bex. So, as based on your lectures, you emphasized the role, the clinical implication of the asymptomatic atrial fibrillation. So, I think the wearable ECG device would detect more frequently the asymptomatic atrial fibrillation, and also the asymptomatic atrial fibrillation has a high risk of a stroke, and also it could end it as the permanent atrial fibrillation. So maybe based on the East Afib net, we could modify the progression of the atrial fibrillation, and also the manage also to handle the clinical outcomes in these populations. So, Dr. Lee, do you have any perspective on the wearable ECG device for clinical decision making?
I think we already widely use the wearable ECG device in our clinical decision making, and as Dr. Beck and Dr. Che mentioned, that highly symptomatic patients and friendly to use their own device, then consumer initiated device like smartwatch is very helpful to detect their hidden arrhythmia. And in older patients and patients who did not have definite symptom, then we can use long-term patch adhesive ECG monitoring to find some clinically significant arrhythmia in that population.
Mm-hmm. So Dr. Lee also showed that very interesting 3 cases using the wearable device. So it's very it's very useful to detect the paroxysmal atrial fibrillation and paroxysmal tachycardia events. So not only the Holter monitoring, but also this kind of a wearable device could detect those kind of arrhythmia more easily and more frequently. So I think we could move on to the next questions. So what are the clinical indications for using the single lead ECG device? I think Dr. Park showed a very brilliant study, the Signal Afib study, maybe the ischemic stroke, and also some kind of specific populations which this kind of wearable device could work more. Dr. Park, could you please answer this question?
Yes. As you mentioned before, single lead ECG has clinical implication in daily life. So recent guideline in European or American or Korean heart rhythm guideline, the opportunistic ECG monitoring in general population and the systemic ECG monitoring in high-risk patient was recommended. But systemic ECG monitoring is not easy in daily life. So just we should visit hospital for detection atrial fibrillation with using systemic ECG monitoring. So in terms of the daily life AFib detection, single lead ECG has more clinical implication. And as mentioned before, the sensitivity or specificity of single lead ECG has been increased compared to previously. Finally, the single lead ECG is very cheap than the systemic ECG, so we can use easily with low cost. We can detect atrial fibrillation with using single lead ECG. So I recommend the single lead ECG in a daily life if the patient has a palpitation symptom.
Mm-hmm.
Yeah.
So to add on the Dr. Park's comments, so I think one of the important feature is that we can detect atrial fibrillation, silent atrial fibrillation or asymptomatic atrial fibrillation, especially for those who are have the embolic ischemic stroke. So maybe if we just use a 24-hour Holter monitoring, then the chance of the detecting atrial fibrillation would be lower. If we use like a 7 days continuous ECG monitoring, then we could detect more frequently the atrial fibrillation, which would be not detected by the Holter monitoring. So I think maybe if we find the atrial fibrillation in those patients, then we could start the anticoagulation therapy. So maybe this kind of a clinical implication would be very important. So I would like to move on to next question. So thank you for great lectures. Any specific caution for the patient who are advised for solo? So do you have any experience using the solo and to advise the patient? Dr. Beck, do you have any experience?
Yes, I have experienced with almost one patient. I attached the solo cardiac attached decision. Sorry. Okay, so I experienced the one patient with cardiac solo with some little is the problem is the patient is very satisfied with this solo device, but our little problem is skin irritation and problem. So I think about this problem is skin ointment for irritation is very useful this problem. So I recommended this solution.
I think there is a small number of patients who got some kind of skin irritation when you use the solo device. So maybe very sensitive skin, such as atopy dermatitis patient would not be very good candidate for. But most of the people does not have any specific problem related to skin. So what about the small body weight and the small statues, especially for the Asian population? So Dr. Lee, do you have any ideas? Can we use those solo device, especially for the very small BMI and body weights?
Actually, I do not have much clinical experience use solo, but I think that the small body size is not the problem, because in opposite side, the larger body size can be a problem, because it can be far from the heart, but small body size or the limb body can not make the signal quality, make the problem for signal quality or the detection ECG. But and is there a report for the size of the patchy for Asian population?
I think there's only one size for solo, but we have several patients, but we don't have any special problem related to the size, body size. So I think even in the small size patients, then we can prescribe the solo. We can attach the solo successfully. So I think this is another interesting, the practical questions for heavy sweating patients. So what is the advice to prevent detachment? Dr. Park, do you have any specific ideas on this population?
Yes, very the practical question. So previous mentioned that the STOPS AF study shows that event Holter type single lead ECG showed also the similar Afib detection rate compared to single lead continuous monitoring ECG. So in this case, I recommend the cardiac mobile, such as event Holter type single lead ECG. Yes, the detection rate of Afib is similar to the patch type single lead ECG. Yeah.
Okay, thank you. So we are moving to another questions. So what is Korean hospital clinical routine for interpretations and reporting of solo? How much time is necessary for one case? So maybe I can answer this question. So in Korean hospital clinical routine, so actually the solo is not covered by reimbursement. So we cannot prescribe or we cannot order the solo for clinical routine use. But we are now running the clinical study to validate the solo versus Holter monitorings, and we have several experience. And now for each case, about less than 10 minutes are needed to interpret the 7 days solo data. So it's not quite long times. Very few times are needed to interpret it and reporting the solo system. So I think this is a very convenience, and this is a very unique aspect of solo device, because in the Holter monitorings, the specialist has to read first, and then the physician has to read second. That it will need several minutes, several hours, even if we interpret all the 7 days monitoring. So I think Dr. Bach mentioned about the automatic algorithm to detect the atrial fibrillation, and this kind of a device would be the future of the detecting the arrhythmia. So I think we can move on to the next questions. So do you think it is a good idea to use single lead patch type ECG for syncope patient who came through ER? So this is quite interesting questions, that not only the atrial fibrillation but also other arrhythmia. So Dr. Beck, can you what is your thought on the clinical role of single lead patch type ECG for syncope patient?
Yes, I think it is very useful for syncopation in this patch disease type ECG, because event recorder such as smartwatch and conventional event recorder is not catch the syncopation because of very short time or symptom. So I think though is longer and longer continuous monitoring is very important for syncopation. Now is recommended unknown origin syncopation is susceptible is implantable loop recorder, but many patients we know is this is in especially South Korea is invasive procedure is refused this procedure in many patients. So I think the 7 or 14 days this like single with patch disease is very useful for this patient.
Yes, that's a very great answer. So I think not only to detect atrial fibrillation, but also the bradycardia and also the ventricular tachyarrhythmia, and that kind of arrhythmia could be the cause of the syncope. So maybe the single lead type patch type ECG would be very useful. If they have longer duration of monitoring, then it would be improve the sensitivity to detect such kind of clinically important arrhythmia. So I think this is the last questions we could discuss. So what is is there a role for single lead ECG patch in post-ablation atrial fibrillation? So so far we are using the Holter monitoring as the routine use to monitoring the post-ablation of Afib. So what is your thought, Dr. Lee? Do you have any thoughts of such kind of a single lead ECG patch?
Now in my practice, I use 24-hour Holter monitoring in 3 months after ablation and 1 year after ablation. And Actually, I have some experience that extended single-lead ECG patch after the ablation patients, and as we already mentioned in our presentation, the diagnostic or detection yield of AF after post-ablation is higher than 24-hour Holter monitoring because it's extended monitor. So we can decide many things from based on the continuous monitoring after post-AF ablation. We can control the antiarrhythmic agent for patients' Afib burden or the bradycardia or the transient pause after the ablation. And we can, there is a lack of evidence on the stop anticoagulation after Afib ablation, but in the future we can decide the stop anticoagulation after the Afib ablation and Afib. If there is no Afib, the repeated extended ECG monitor. So many things can be decided from extended single-lead ECG monitor after AF ablation.
Mm-hmm. So thank you, Dr. Lee. Do you have any comments, Dr. Park? What about the not only the single-lead ECG patch, but what about the wearable watch type or other device, such as you mentioned about the live core, the cardia, after the monitoring of the atrial fibrillation after the post-ablation?
Yes, post-ablation AF is the important to detect AF accurately. So the single-lead ECG is very important to clinical implication in post-ablation AF. In my case, our hospital they usually use single-lead ECG. So after ablation, all patient the experienced the single-lead ECG every 3 months, until 1 year. So after that, the recurrence rate of atrial fibrillation is a little higher than conventional Holter, 12 hours Holter. Even though that I usually use single-lead ECG, the most patient the preferred single-lead ECG. If the patient experienced the single-lead ECG, the never patient they refuse conventional 12 hours Holter. So I usually use a single-lead ECG after operation.
Yes, thank you. I agree totally with your opinion. And as an electrophysiologist, after the Afib ablation, especially those who have the pacemaker or ICD, the recurrence rate of after Afib ablation is very higher than just if we use only the Holter monitoring to detect atrial fibrillation. But I think it's time to use the single-lead ECG patch into our clinical practice, the Afib ablation, if we have to improve our success rate and improve our clinical practice in those patients. So I think it is time to finish our today's webinars. Thank you for all the time. Thank you for the APAC physician and the speaker joining the summit today. I have the comments that we have around 150 electrophysiologists and cardiologists registered from the 12 countries, including Taiwan, Hong Kong, Mongolia, Thailand, Vietnam, Singapore, Malaysia, Cambodia, Bangladesh, as well as Australia. I think this is the first webinar hosted by i.SigNal by DreamTex. And I think this is not only the first time, but it's the beginning of this kind of a webinar symposium. So next time, I think it will be nice to invite the electrophysiologists and cardiologists to share the most recent clinical knowledge about early detection of the atrial fibrillation case in near futures. So I think, again, thank you for the DreamTech to organize all these webinars, and have a wonderful night. And we will be looking forward to meet you in near futures. So thank you again.